Good morning, everyone, and today's lecture we will be covering our respiratory system. So, respiration is the process that includes the following. First is ventilation or breathing, in which movement of air into and out of the lungs. It also includes the exchange of oxygen and carbon dioxide between the air in the lungs in the blood. It also involves the transport of oxygen and carbon dioxide in the blood and the exchange of oxygen and carbon dioxide between the blood and the tissues. So, to simplify it, respiration will include the transfer of physical air from the atmosphere into your lungs, and it will facilitate the movement of carbon dioxide and oxygen from the lungs to your blood to your tissues, and the reverse process is also true. So these are the functions of our respiratory system. First is the regulation of blood pH. The respiratory system can alter blood pH by changing blood carbon dioxide levels. This will be explained later. It just means that the more carbon dioxide you have, the more acidic your blood pH will be. Next is it is also involved in our voice production, in which air movement past the vocal cords makes sound and speech possible. Next is olfaction. The sense of smell occurs when airborne molecules are drawn into the nasal cavity, and it also plays a small part in our immunity, in which the respiratory system protects against some microorganisms and other pathogens. So the organization of our respiratory system is divided into two. We have the upper respiratory tract, which includes the external nose, the nasal cavity, the pharynx, and associated structures. We also have our lower respiratory tract, which includes the larynx, the trachea, the bronchi, and the lungs. So you might encounter in your future work the words URTI, which is upper respiratory tract infection. This means that only the upper part of your respiratory tract is infected with something. If we have lower respiratory tracts infection, it means it is most likely the lungs which is affected, like pneumonia. So this is our upper respiratory tract. It involves the nose, the nasal cavity, the sinuses, and the pharynx. Okay, so in your x-ray view, this is what it will look like. This is the lower respiratory tract. So this is the most common x-ray performed. It is used to visualize the field of view in your lungs. Again, a image dividing our respiratory tract into upper and lower parts. So the nose consists of the external nose and the nasal cavity. So both what the nose you can see in other persons and what is inside the nose, especially the cavities. So the external nose is mostly composed of hyaline cartilage, and the bridge consists of bone. That is why sometimes when you punch someone, they will end up with a broken nose that needs to be realigned. It also includes our nasal cavity, which extends from the nares to the conchae. Its superior part contains the sensory receptors for the sense of smell, and the rest of the nasal cavity is lined with pseudostratified columnar epithelial cells, which contains cilia and most of our mucus-producing goblet cells. So goblet cells are the cells that produce mucus. So mucus is produced by goblet cells, which traps debris like dust and pollen in the air before it enters your lungs. The cilia sweep the mucus posteriorly to the pharynx, where it is swallowed. So that is your first line of defense against particulate matter. So here are the different parts of the nose. First, we have our nares or our nostrils. This is the external openings of your nose. So it is the one responsible for letting air into your nose. Next, you have your choana, which are the openings into the pharynx. You also have your nasal septum, a partition that divides the nasal cavity into left and right parts. So this is just below the bone in the middle of your nose. You also have your hard palate. This forms the floor of the nasal cavity, separating the nasal cavity from the oral cavity. So here's the cadaver view of the parts of the nose. Again, more a cross section to see the different parts of our nose. A closer view of our nasal septum. It is divided into three planes, which is our vomer, our perpendicular plate, and our septal nasal cartilage. Okay, so this is an MRI view of our nasal Conchae. Again, we have our Conchae, which is a structure made out of bony ridges found on the lateral walls on each side of our nasal cavity. This role is to increase the surface area of our nasal cavity and cause air to churn, meaning the air you breathe in is not a straight path to your lungs. So it actually regulates the speed of how air enters your lungs. The main its roles is in cleaning, humidifying, and warming of the air before it enters your lungs. Next, you have your paranasal sinuses. These are air-filled spaces within the bone and include the maxillary, frontal, ethmoidal, and sphenoidal sinuses. Open into the nasal cavity and are lined with mucous membrane. This reduces the weight of the skull. It also produces mucus and influences the quality of the voice by acting as resonating chambers. So you wouldn't sound flat. So these are the different sinuses. You also have your nasal lacrimal ducts. These are also open into the nasal cavity. So you might experience when you have a crying fit or when you cried, lagi po kayong parang nagbi-build up yung fluid sa inyong ilong. That's because of your nasolacrimal ducts. Next, you have your nasal hairs, which are the first particle filtration system. Just inside the nares, these trap particles of dust suspended in the air, preventing it from entering your lungs. Your sneeze reflex dislodges foreign substances from the nasal cavity, provided that you have enough dust or you have inhaled something irritating, you will sneeze by reflex. Next, you have your pharynx. This is commonly called the throat. It is a common passageway for both the respiratory and digestive systems. It can be divided into three regions: the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx is the superior part of the pharynx. It joins the nasal cavity through the... So we have our pharynx. This is commonly called your throat. Commonly, common passageway for both the respiratory and digestive systems, can be divided into three regions: the nasopharynx, the oropharynx, and the laryngopharynx. So your nasopharynx is the superior part of the pharynx, joins the nasal cavity through the choana, and contains the openings to the auditory tube and pharyngeal tonsils. So you might notice that our auditory system is intertwined with our respiratory system. This is why we have doctors that specialize in the ears, eyes, nose, and throat. It's because these are all chambers that are linked together. Next, we have our oropharynx. This is the middle portion of the pharynx. It joins the oral cavity and contains the palatine and lingual tonsils. We also have our laryngopharynx, which is the inferior portion of the pharynx and opens into the larynx and the esophagus. Okay, so this is the cross-section of our pharynx. So the nasopharynx is the topmost, oropharynx is the middlemost, and laryngopharynx, which is the bottommost. Okay, this is an MRI view of our pharynx. Another cross section showing you the different septums and the different parts of our upper respiratory tract. Tonsils, we have discussed this back in our immunity. Okay, and a complete identification of parts for our respiratory tract, upper respiratory tract. Okay, now you have your larynx. Your larynx is also called your voice box. It is a passageway for air between the pharynx and the trachea. Consists of 3 unpaired cartilages. When we say unpaired, these are larger cartilages that is only one piece. You have your thyroid cartilage, cricoid cartilage, and your epiglottis. And 6 paired cartilages, your cuneiform, your corniculate, and your arytenoid. So these are our unpaired cartilages. First, we have our thyroid cartilage, also known as your Adam's apple. This is the largest cartilage and also shield shape. Composed of the hyaline cartilage, its main role is to maintain an open passageway for air movement. Next, you have your cricoid cartilage. The most inferior cartilage, composed of hyaline cartilage, forms the base of the larynx on which other cartilages rest and maintains an open passageway for air movement. And you have your epiglottis, which consists of elastic cartilage rather than hyaline cartilage. It helps prevent swallowed materials from entering the larynx. So this is the one that closes and opens depending on if you swallow or if you breathe. Next, you have your paired cartilages. This consists of 3 cartilages on each side of the posterior part of the larynx. It forms an attachment site for the vocal folds. You have your cuneiform, your corniculate, and arytenoid. So your cuneiform is wedge-shaped, the top cartilage on each side. You have your corniculate, which is horn-shaped, the middle cartilage, and you have your arytenoid, which is the ladle-shaped, the bottom cartilage. So this is the isolated view of our larynx. So some highlighted portions describing or identifying which part of the larynx for the posterior view. Okay, you can see more parts hidden by our thyroid cartilages from our posterior view. Other parts of our larynx is our vestibular folds. These are also called your false vocal cords. These prevent air, food, and liquids from passing in through the larynx. Next, you have your vocal folds or your true vocal cords. Primary source of voice production, vibrate and produce sounds when air passes through the larynx. The force of air movement controls loudness, and changes in the length and tension of the vocal folds determine pitch. Laryngitis is a condition of the mucous epithelium of the vocal folds. Swelling of the vocal folds during laryngitis inhibits voice production. So this is common in our artists whose main job is by voice. So this is the lateral view of our larynx. And a more illustrated view of the different parts of our larynx. Okay, this is a superior view of our larynx. You can only see this if you use a laryngoscope, which is a special device to let you see the throat. Next, you have your trachea, also called your windpipe. This connects the larynx to the main bronchi, consists of 16 to 20 C-shaped pieces of hyaline cartilage that protect the trachea and maintain an open passageway for the air. The adult trachea is about 1.4 to 1.6 centimeters in diameter and about 10 to 11 centimeters long, lined with pseudostratified columnar epithelium containing numerous cilia and goblet cells. Okay. Constant long-term irritation of the trachea by cigarette smoke can cause the tracheal epithelium to change to stratified squamous epithelia, which has no cilia and therefore cannot clear the airway of mucus and debris. Constant irritation and inflammation of the respiratory passages stimulate the cough reflex, resulting in smoker's cough. So this is also common in our patients with COPD. And our trachea is one larger branch that divides into the left and right bronchi. So this is your trachea. The one in the right side is the pairs or the C-shaped cartilage that helps maintain the shape of the trachea. Okay, as you can see, your trachea will divide into two, or it will branch into two parts in the middle. Next, you have your bronchi. So your main bronchi extends from the trachea to the lungs. It is lined with pseudostratified ciliated columnar epithelium and are supported by C-shaped pieces of cartilage, similar to your trachea. Here you go. So these are the main bronchi. Okay, so this is your trachea. This is your trachea, and afterwards, it will separate into your left and right bronchi. Next, you have your lungs. These are the principal organs of respiration. These are cone-shaped, with its base resting on the diaphragm and its apex extending superiorly to a point about 2.5 centimeters above the clavicle. The right lung has 3 lobes, superior, middle, and inferior, while your left lung has 2 lobes. Why doesn't your lungs have an equilateral division, meaning why aren't they the same? It's because your left lung is close to your heart, in which your left lung accommodates the shape of your heart. And this is the air passageways of the lungs. So upon inhalation of air, this is the flow of air from your nose down to your lungs. So as you go down, the size or the diameter decreases. However, as you also go down, the surface area also increases. The greater your surface area is, the more gas exchange can occur. That is why your alveoli, although they are very small anatomically, they have the largest surface area because of their small size. So the air passageways of the lungs branch, they decrease in size, but they increase in number. The main bronchi form the lobar bronchi, which go to each lobe of the lungs. The lobar bronchi form the segmental bronchi, which extend to each bronchopulmonary segment of the lungs. The segmental bronchi branch many times to form the bronchioles. The bronchioles then branch to form the terminal bronchioles, which give rise to respiratory bronchioles, from which alveolar ducts branch. Alveoli are the air sacs connected to the alveolar ducts and respiratory bronchioles. Okay, so as you can see, as you go from a larger diameter, it goes to a smaller diameter. However, the surface area does increase greatly. So you have your left and right lungs. Okay, so let's start with the right lung. We have 3 lobes. You have your superior lobe, your middle lobe, and your inferior lobe. What divides them is two fissures that can help you identify which is being highlighted. So your horizontal fissure will divide your superior lobe and your middle lobe here. While your oblique fissure will separate your inferior lobe to your middle lobe. So you can see that there's a triangular portion of the middle lobe near your heart. As for your left lung, there is only two parts, your superior lobe and your inferior lobe, which is separated by your horizontal fissure. Okay, so you have your cardiac impression. So the cardiac impression is actually the space provided for your heart when it is fully functional. So you can see it here because this cadaver is dead. Okay, so have your chest X-ray and your bronchogram. Okay, so I'm not a radiologic technologist. However, if ever you're going to take a look at the lungs, normal chest X-ray, what they are looking for in a normal chest X-ray is this part here. They're not actually looking at the white parts, but they are looking at the black parts. It should be dark. There should not be any white spots present in the area that is supposed to be dark. Otherwise, it can indicate a mass or an infection. Okay, they're also looking at the size of the heart. If your heart is enlarged, experienced radiologic technologists can identify that there's an enlargement of your heart. So you have your pulmonary circulation here. Your pulmonary fresh blood will come out from your heart to your left lung, to both lungs. Okay, so this is a illustration which can better show you the differences. I mean, the anatomy of your heart. Okay, so we have other parts of the lungs. You have your alveoli. These are small air sacs formed by simple squamous epithelium. They facilitate diffusion of gases. About 300 million of alveoli is present in your lungs. These are very small. So asthma attack, if ever you have asthma, this is contraction of the smooth muscle in the terminal bronchioles, which greatly leads to reduced airflow. Medications such as albuterol or salbutamol help counteract the effects of asthma by promoting smooth muscle relaxation in the walls of the terminal bronchioles so that air can flow more freely. Okay, so asthma itself is a condition which is pseudo-permanent, meaning it can persist throughout your life, and proper management of asthma is needed to decrease the intense asthma attacks and hospitalizations or emergency room visits. So this is the histological view of our alveoli. Another histological view of our lung tissue. Okay, now we have our respiratory membrane. This is where gas exchange between the air and blood takes place. Formed mainly by the walls of the alveoli and the surrounding capillaries, this is a very thin membrane to facilitate the diffusion of gases. So these are the different layers of the respiratory membrane. First, we have a thin layer of fluid lining the alveolus. Next, you have your alveolar epithelium composed of simple squamous epithelium. The basement membrane of the alveolar epithelium, a thin interstitial space, the basement membrane of the capillary endothelium, and the capillary endothelium composed of simple squamous epithelium. Okay, So this respiratory membrane is very important in our alveoli because this will facilitate the movement of gases. Okay? The other side needs to be vascularized so that blood can flow, and the thickness should be just right so that gases can penetrate the layer. Okay, so you have your pleural membranes and cavities. So what is pleura? Pleura is a serous membrane around the lungs. You have two types. You have parietal pleura, which is a serous membrane that lines the walls of the thorax, the diaphragm, and the mediastinum. And you have your visceral pleura, that surround serous membrane that covers the lungs surface. The pleural cavity is the space between the visceral and parietal pleura filled with pleural fluid, a cavity that surrounds each lung. Okay, so the pleural fluid acts as a lubricant, allowing the visceral and parietal pleura to slide past each other as the lungs and thorax change shape during respiration. It helps hold the pleural membranes together. Okay, so your visceral pleura is directly covering the lungs. The outermost portion is your parietal pleura, and the space in between your parietal and visceral pleura is your pleural cavity. Okay, so this is the parietal and visceral pleurae in our cadaver. And this is a cross-section of a superior view of the lungs. So our lungs also have a lymphatic supply in which there are superficial lymphatic vessels that are deep to the visceral pleura. They drain lymph from the superficial lung tissue and the visceral pleura, and deep lymphatic vessels drain lymph from the bronchi and associated connective tissues. Both the superficial and deep lymphatic vessels exit the lungs at the main bronchi. Okay, so let's talk about ventilation and breathing. So what is it? It is the process of moving air into and out of the lungs, regulated by changes in thoracic volume, which produce changes in air pressure within the lungs. We have two phases of ventilation: inspiration, which is the movement of air into the lungs. So if you have to see, in, and you have X, which is exit, the movement of air out of the lungs. So if you ever experience the morning exercise with inhale exhale, this is what you are being asked to do. So the muscles of inspiration include the diaphragm, the muscles that elevate the ribs and the sternum, such as the external intercostals. So the diaphragm is a large dome of skeletal muscle that separates the thoracic activity from the abdominal cavity. And your muscles of expiration also include your internal intercostals that depress the ribs and the sternum. Okay, so you have your diaphragm here. Okay, it actually pushes your lungs a bit. Okay, so this is your diaphragm again. This is your phrenic nerve, which is directly connected to your diaphragm. You have your external intercostals that aids the diaphragm in inspiration. Okay, so, and you have your internal intercostals, which performs the act of expiration. Okay, so these are the connectivity of the muscles during inspiration and expiration. So if you are going to inspire air, the diaphragm will contract. The diaphragm will contract and increases the dimension of the thoracic activity, in which air will enter your lungs, and when it is finally time to exhale, your diaphragm will now relax, forcing your lungs to compress and your air inside your lungs to exit. Some additional muscles present is your pectoralis minor and your sternocleidomastoid muscle. This controls your chest. Some additional muscles that controls your chest and your abdomen, external abdominal obliques, your internal obliques, and your transverse abdominis. Okay, some more muscles and their highlighted parts. And this is the whole abdominal muscles. Okay, so let's talk about the physics of your breathing. So, pressure changes and airflow. Two physical properties govern the flow of air into and out of the lungs. First is changes in volume results in changes in pressure. Okay, so as the thoracic cavity volume increases, the pressure decreases. And as the thoracic cavity volume decreases, the pressure increases. So there is an inverse relationship within your pressure and volume. Okay. Next is air flows from an area of higher pressure to an area of lower pressure. Meaning that if the air outside, meaning the atmosphere, has a higher pressure than in your lungs, it means that air will flow into your lungs. If the pressure inside your lungs is higher than the atmosphere, air will flow out of your lungs into the air. Okay? So when inspiration happens, the diaphragm descends and the rib cage expands. Thoracic cavity volume increases and the pressure decreases. And when it decreases, it will be less than atmospheric pressure, meaning air will move into your lungs. On the other hand, when we have our expiration, diaphragm relaxes and the rib cage recoils. The thoracic cavity volume decreases, meaning nagko-compress ang ating chest, and pressure increases, causing the alveolar pressure to be greater than atmospheric pressure. Air moves out of the lungs. Okay, so this is the diagram for representing the pressure changes between inspiration and expiration. Okay, next you have lung recoil. So what is lung recoil? It is the tendency for an expanded lung to decrease in size. It occurs during quiet expiration and able to occur due to elastic fibers and the surface tension of the fluid lining the alveoli. Next, you have your surfactant. So surfactant, in an anatomical sense, is a mixture of lipoproteins produced by secretory cells of the alveolar epithelium. It forms a single layer on the surface of the thin fluid layer lining the alveoli, reducing surface tension. It greatly reduces the tendency of the lungs to collapse. Next, we have our pleural pressure. So what is it? So it is the pressure in your pleural cavity. When pleural pressure is less than alveolar pressure, the alveoli tend to expand. It keeps the alveoli from collapsing. So how do we change alveolar pressure? So if we increase thoracic volume, we decrease pleural pressure. And we increase alveolar volume but decrease alveolar pressure. With a low alveolar pressure, air will come into the lungs. Decreasing thoracic volume results in the opposite. It will lead to increased pleural pressure, decreased alveolar volume, and increased alveolar pressure, and the air will now move from out of your lungs into the air. So these are some factors that may influence your pulmonary ventilation. Number 1 is your lung elasticity. Lungs need to recoil between ventilation, meaning it's like the heart, and it may be decreased by emphysema. So emphysema is the entry of fluid in your lungs, around your lungs. So parang nagkakameron ng fluid sa gilid ng lungs. Next is lung compliance, which is the expansion of thoracic cavity. Affected if the rib cage is damaged. And respiratory passageway resistance occurs during an asthma attack, infections, and tumors. So these are the ways to measure our respiratory volumes and capacities. So if you are going to aim for being a respiratory technologist, so if gusto nyo, malaking sahod din sa US, these are the tools you will be using. So spirometry is the process of measuring volumes of air that move in and out of the respiratory system. A spirometer is the device that measures respiratory volumes, and a respiratory volume measures the amount of air movement during different portions of ventilation. Respiratory capacity is the sum of two or more respiratory volumes, which we will be discussing next. Okay, so we have 4 measurements of respiratory volume. First, we have our tidal volume, the volume of each air inspired or expired with each breath, about 500 milliliters. So ito po yung amount of air na inihihinga ninyo na hindi pilit. Yung normal breathing ninyo, that is your tidal volume. So if you are breathing right now, na hindi nyo manualing kinokontrol, that is the tidal volume. Yung amount ng air na hinihinga nyo at nilalabas, that is your tidal volume. Next, you have your inspiratory reserve volume, the amount of air that can be inspired forcefully beyond the resting tidal volume. This is about 3 liters or 3,000 ml. So, kaya nyong piliting huminga. Kaya nyong pilitin huminga more than your normal breathing. Example, if I tell you to breathe deep, hingang malalim, you can actually fill about 3 liters of air in your lungs. So that is your inspiratory reserve volume. So kaya tayo may reserve volume is in cases na kailangan nating humabol ng oxygen sa katawan. Next is your expiratory reserve volume. This is the amount of air that can be expired forcefully beyond the resting tidal volume. So if I ask you to exhale, you can about 1.1 liters. Pwede ba kayong mag-exhale? Beyond that, wala na kayong bibigay. And residual volume is the volume of air still remaining in the lungs in respiratory passages and lungs after maximum expiration. So ito yung hindi nyo na maibubuga pa. May laman na hangin ng inyong lungs, pero it is not possible anymore to breathe it out. Kumbaga, try nyo pilitin. Alam nyo meron pero hindi nyo na kaya ibuga. Okay, so we have our respiratory capacities. So first, we have our functional residual capacity. This is the expiratory reserve volume plus the residual volume. So kanina, kita nyo, ito, 1,100 and 1,200. So ito yung kumbaga capacity ng lungs ninyo, 1,100 plus 1,200. That is around 2,300 at rest. Next, you have your inspiratory capacity. This is the tidal volume plus inspiratory reserve volume. So since ang ating tidal volume earlier is 500 ml and our inspiratory reserve volume is 3000 ml. The inspiratory capacity is around 3.5 liters or 3,500 milliliters. Next, you have your vital capacity. The vital capacity is the sum of their inspiratory reserve volume, the tidal volume, and expiratory reserve volume. This is the maximum volume of air that a person can expel from the respiratory tract after inspiration. So this is about 4.6 liters or 4,600 milliliters. And you have your total lung capacity. This is the sum of the inspiratory and expiratory reserves, the tidal volume, and residual volumes, totaling of 5.8 liters or 5,800 milliliters. This also equals your vital capacity plus the residual volume. Okay, so this is a diagram that can help you visualize the different parts of your volumes. Okay, so these are the factors that may influence respiratory volumes and capacities. Number one is sex, size, and body size. So sex is males usually have a larger chest, leading to a larger respiratory volume. Age is youth. Younger people usually have a larger respiratory volume that is slowly decreasing as you age. And body size, meaning taller persons have a greater vital capacity than short people. And thin people have a greater vital capacity than obese people. Please take note that well-trained athletes can have a vital capacity of more than 30% than compared to untrained people. In patients whose respiratory muscles are paralyzed by spinal cord injury or diseases such as poliomyelitis and muscular dystrophy, the vital capacity can be reduced to values not consistent with survival. Next, we have your FEV or your forced expiratory vital capacity, the rate at which lung volume changes during direct measurement of the vital capacity. This can help identify conditions in which the vital capacity might not be affected but expiratory flow rate is reduced. Okay, so we have gas exchange. This is the exchange between air and blood that occurs in the respiratory membrane of the lungs. The major area of gas exchange is in our alveoli, and some takes place in the respiratory bronchioles and alveolar ducts. Please take note it does not occur in our bronchioles, bronchi, and trachea. So these are the larger features of our lower respiratory tract. This is influenced by the thickness of the membrane, total surface area, and the partial pressure of gases across the membrane. So let's first tackle respiratory membrane thickness. So as you increase the thickness of the respiratory membrane, it is inversely proportional with our gas exchange, meaning the thicker your respiratory membrane is, the less gas exchange occurs. This is because there is a larger traversal needed for the gas exchange to occur. Next is our surface area. So total surface area of the respiratory membrane is about 70 square meters in a normal adult. And small decreases in the surface area can adversely affect gas exchange during strenuous exercise. So as surface area increases, gas exchange also increases. So surface area is directly proportional to our gas exchange rate. Okay, so some factors that may lead to a decreased surface area includes removal of lung tissues, either by destruction or by cancer, the degradation of the alveolar walls by emphysema, so this can lead to decreased gas exchange. Next, we have our partial pressures. So partial pressures is something in physical chemistry that is discussed fully. However, to make it short, substances exert a certain amount of pressure when in a mixture. Okay, assuming we are using an ideal gas, the amount of pressure in the total amount of pressure in the atmosphere at sea level is 760 millimeters mercury, or 1 atmosphere. Since 21% of the mixture is made out of oxygen, the partial pressure for oxygen is around 160 millimeters mercury. Okay, the same computation also applies for carbon dioxide. Since the composition of air is around 0.04% carbon dioxide at the same atmosphere, the partial pressure for carbon dioxide at sea level is 0.3 millimeters mercury. Okay, so this will be our data moving forward: 160 millimeters mercury for our oxygen and 0.3 millimeters mercury for our carbon dioxide. Okay, now first, oxygen diffuses into the arterial ends of the pulmonary capillaries, and the carbon dioxide diffuses into the alveoli because of differences in partial pressures. So partial pressures is also a type of pressure. Okay, so this is for inspired air. So since our partial pressure of our alveoli, so this comes from our air, is 104, and the partial pressure of oxygen in your blood is around 40, the flow of oxygen is inwards to your blood. Okay, remember that air will flow from a region of higher concentration to a region of lower concentration. So meaning kung saan mababa ang pressure, dun pupunta ang oxygen. So in terms of oxygen, 104 sa alveolus, 40 sa blood, papasok siya. Okay? And since ang partial concentration or our partial pressure of carbon dioxide in our alveolus is 40, and the concentration of our partial pressure of carbon dioxide in our blood is 45, the flow of carbon dioxide is outward. Okay? So this will occur until it reaches equilibrium, meaning the partial pressures of both in the partial pressures of oxygen and carbon dioxide is equal to the partial pressures of carbon dioxide and oxygen in your alveoli. So in this part here, you can see that it is actually in equilibrium. Okay, as it moves to other parts of your body, it will reach tissues. Okay, it will enter your tissues. So normally, your tissues contain less oxygen. Okay, so since it has less oxygen, oxygen in your blood will enter tissues. And the opposite is true for carbon dioxide. So carbon dioxide tends to build up in tissues, and it is greater than the one in your blood, causing it to move towards your blood. So this is the gas exchange. Ang oxygen ng inyong dugo pumapasok ng ating tissues kasi ang oxygen sa tissues ay mas kokonti kaysa sa oxygen ng dugo. The same is true with our carbon dioxide. The amount of carbon dioxide in the blood is less than the amount of carbon dioxide in your tissues, causing the carbon dioxide in your tissues to go towards the blood. Again, it will reach a certain equilibrium point in which the amount of oxygen and carbon dioxide both in your tissues and in your blood is exactly the same, and it will flow back into your alveolus, where the process will repeat itself, and this is your gas exchange. Okay, so diffusion of gases in the lungs. So cells of the body use oxygen and produce carbon dioxide as the byproduct. So in metabolism, oxygen is used in ATP, and eventually carbon dioxide will be produced. So blood entering from the lungs, from the tissues, and entering the lungs has decreased partial pressure of your carbon dioxide and increased partial pressure of carbon dioxide. Oxygen diffuses from the alveoli into meaning this is from outside going in towards your blood, and carbon dioxide is moving from your pulmonary capillaries to your alveoli. So this is inside out, outside in. So I think I already discussed this. So if you want to go back to my explanation, please feel free to do so. I will not be reading this anymore. Okay, so this is the gas exchange in your lungs, in which carbon dioxide can actually react with water to form carbonic acid. Okay, and your carbonic acid will dissociate into bicarbonate and free hydrogen ions. Okay, so this is the result actually of what we are talking about earlier in pH. Okay, remember what pH is? I think you have chemistry classes. So pH is the amount of hydrogen ions in the blood. Amount of hydrogen ions. Okay, it is actually the inverse log, negative log H. Okay, so anyway, to make it short, okay, as carbon dioxide increases, carbonic acid will also increase. And if you have greater amounts of carbonic acid, you will also have increased amounts of hydrogen ion. And since hydrogen ion forms acids or represents our acidity, the more hydrogen ion you have, the lower your pH is. Remember, class, that pH is the negative logarithm, meaning the more hydrogen ions you have, the lower your pH is, the more acidic your blood becomes. Okay, low pH. Let's write it again. High hydrogen ion concentration equals low pH, but it is high acidity. Okay. Well, so when will this be helpful? This will be helpful especially when you're dealing with patients who are suffering from acidosis or alkalosis. So if you are actually experiencing acidosis, the response of your body is to rapidly breathe, to decrease carbon dioxide in your blood, to decrease pH. Okay, so gas transport in the blood. Primarily, we have our oxygen transport, in which at most 98.5% of oxygen is transported in blood by hemoglobin. Around 1.5% of oxygen is transported, it is dissolved in plasma. Oxygen is released from hemoglobin in the tissues where partial pressures for oxygen is low and partial pressures of carbon dioxide is high. pH is low and temperature is high. Okay. Carbon dioxide is transported in solutions in plasma in combination with blood proteins and as bicarbonate ions. In tissue capillaries, carbon dioxide combines with water to form carbonic acid, and carbonic acid will dissociate to form bicarbonate anion and hydrogen ion. This promotes the transport of carbon dioxide. So in lung capillaries, bicarbonate can react with hydrogen ion to form carbonic acid again, and the carbonic acid dissociates to form carbon dioxide, which diffuses out of our red blood cells. As blood carbon dioxide levels increase, blood pH decreases. Remember, when pH decreases, acidity increases. As blood carbon dioxide levels decrease, blood pH increases, meaning your blood becomes more alkaline. Changes in breathing can change blood carbon dioxide levels and pH. Okay, so we have rhythmic breathing. So the normal breathing rate of adults is between 12 and 20 breaths per minute. For children, it may be higher and may vary from 20 to 40. This is because children has less lung capacity than our older people. So the rate of breathing is determined by the number of times respiratory muscles are stimulated. The basic rhythm of breathing is controlled by neurons within the medulla oblongata. Okay, so respiratory areas in the brainstem, the medullary respiratory center, specifically our pre-Botzinger complex, establishes the rhythm of breathing. The pontine respiratory group is a collection of neurons in the pons and has connections with the medullary respiratory center and appears to play a role in switching between inspiration and expiration. Okay, so these are the different parts of your brain that controls breathing. So inspiration begins when stimuli from many sources, such as receptors that monitor blood gases, reach a threshold. So you cannot hold your breath indefinitely. Eventually, your brain will force you to breathe, especially when it detects that carbon dioxide is building up. Expiration begins when neurons causing inspiration are inhibited. So nervous control of breathing. The higher brain centers allow voluntary control of breathing like you are doing now. You are now manually breathing. Emotions and speech production affect breathing. Okay, so if you are upset, most likely, if you are hyperventilating, that's one reason why. And if you are speaking like me right now, your breaths are manually controlled so that it doesn't affect how you are speaking. So the Herring-Brauer reflex inhibits the respiratory center when the lungs are stretched during inspiration. In infants, this plays an important role in regulating the basic rhythm of breathing and in preventing overinflation of the lungs. In adults, however, this is important only when tidal volume is large and occurs during heavy exercise. Touch, thermal, and pain receptors can also stimulate breathing. Okay, so one thing I would like to share, if you ever used aromatic ammonia spirit, yung something aromatic ammonia spirit. So if you are a medic in your ROTC or if you are a nurse assistant or some sort of first aid responder, you will have this in your kit. This is aromatic ammonia spirit. It is basically ammonia covered with alcohol and something fragrant in it. Okay, the smell is so pungent that when you breathe this, it will actually cause your body to recoil and breathe deep. Okay, so this pwedeng gawin nyo sa kanya, ipaamoy sa nahimatay na patient, making them breathe pag nahimatay. Okay, pag nahimatay, paamoy nyo sa kanya, they will breathe deep and hopefully they will regain their consciousness. Okay, if you want to try how it smells pag nagbalik na tayo sa normal, sige, akyat kayo sa aking laboratory at ipapaamoy ko sa inyo kung anong amoy ng ammonia. Talsik uhog nyo doon. Okay, so these are the neuronal control of breathing. So you have your medulla oblongata and your pons in your brainstem. For the chemical control of breathing, carbon dioxide is the major chemical regulator of breathing. An increase in blood concentrations of carbon dioxide causes a decrease in blood pH, meaning in a more acidic blood, resulting in increased breathing. Low levels of oxygen can also stimulate chemoreceptors in the carotid and aortic bodies, also results in increased breathing. Chemoreceptors on the medulla oblongata also respond to changes in blood pH. Usually, changes in blood pH are produced by changes in blood carbon dioxide. Okay, so these are all the methods of how your breathing can be controlled, either by mechanical or mechanical and neural, or by your chemical receptors. So let's talk about some respiratory disorders. So first we have our bronchitis. So inflammation of the bronchi caused by irritants such as cigarette smokes or infections. Swelling impairs breathing and bronchitis can progress to emphysema. So bronchitis is something like COPD. You might be familiar with COPD. Chronic obstructive pulmonary disorder. So this is relative to asthma. How we treat it is similar to how we treat asthma. However, COPD is usually found in patients who are old and who are smokers. Emphysema, if bronchitis is left unattended, it can develop into emphysema. Emphysema is destruction of the alveolar walls. It leads to increased coughing, increases pressure on the alveoli, causing rupture and destruction. So if you lose alveoli, you lose surface area. If you lose surface area, you lose gas exchange. If you lose gas exchange, you basically decrease your capacity for breathing. Okay? Emphysema is irreversible since alveoli does not regenerate. Okay? So, in combination with bronchitis, the condition is also known as chronic obstructive pulmonary disease or disorder. Next, you have your adult respiratory distress syndrome, caused by damage to the respiratory membrane, which promotes inflammation. The amount of surfactant is reduced. The fluid fills the alveoli, lessening gas exchange. So, ARDS usually develops after an injurious event, such as inhaling smoke from a fire or breathing toxic fumes. So, ARDS is actually one of the things in COVID we are currently watching for. Patients with COVID tend to develop this syndrome here. Next, you have your cystic fibrosis. It is a genetic disorder that affects mucus secretions throughout the body due to abnormal transport protein. Mucus is much more viscous and accumulates ducts and tubes, such as the bronchioles. Airflow is restricted and infections are more likely. You also have your pulmonary fibrosis, in which lung tissue with fibrous connective tissue making the lungs less elastic. Exposure to asbestos or coal dust are common causes. We also have lung cancer, in which it occurs in the epithelium of the respiratory tract. It can easily spread to other parts of the body because of the rich blood and lymphatic supply of the lungs. Some infectious disease of our respiratory system. First is strep throat, caused by streptococcal bacteria, Streptococcus pyogenes, characterized by inflammation of the pharynx and a fever. Please do not confuse this with the common cold. Okay, so strep throat, the sign is inflammation of your pharynx. However, it is very close to your common cold. Ang sasakit din po sa inyong common cold is your tonsils. Okay? So most of the time, 95% of the time, pag masakit ang lalamunan nyo, it's not strep throat. Antibiotics will not treat your condition. It is the common cold, the rhinovirus. Hayaan nyo na lang po siyang gumaling ng kanya. Okay? Bakit masama ang loob ko dito? It's because being a pharmacist, every day, someone will always ask for antibiotics to treat their cold. And every day napapaaway. Okay? So next we have diphtheria, caused by the bacterium Corneobacterium diphtheriae. A grayish membrane forms in the throat and can completely block respiratory passages. DPT immunization for children partially targets diphtheria. Next, you have your common cold, results from a viral infection. There is no treatment for the common cold because of the wide variety of strains that cause this one. So, if you have the common cold, wala, magpahinga ka lang, gagalingin ang kanya. Next is your whooping cough, caused by the bacterium Bordetella pertussis, which destroys cilia lining in the respiratory epithelium, allowing mucus to accumulate. It leads to very severe cough. DPT immunization for children partially targets pertussis. So, magkasama siya ng ating diphtheria vaccine. Next, you have tuberculosis, caused by the bacterium Mycobacterium tuberculosis, which forms small lump-like lesions called tubercles immune system targets tubercles and causes larger lesions. Certain strains of tuberculosis are resistant to antibiotics. If you are asked anong tawag doon, it is called MDR-TB. Multi-drug resistant tuberculosis. Okay. So tuberculosis in the Philippine context is tuberculosis is everywhere in the Philippines. It's not rare. It's not rare to see patients with tuberculosis. However, we do have the BCG vaccine that protects us from tuberculosis. However, sometimes even if you are vaccinated, minsan tinatamaan pa rin. And some patients who are not vaccinated are more susceptible to tuberculosis. Okay, tuberculosis was deadly back in the 80s or 70s. However, now, due to the advancement of drugs with our combination treatment and we have our TB dots, around 6 months of treatment, you will be actually free of tuberculosis. If you're curious what dots means, it means direct observed treatment, short course. Okay? So, pag nakita nyo yung TB dot center, they do not house TB patients. They actually, parang lugar lang siya para mag-administer ng gamot. The DO in dots, directly observed, means that when you're going to take the drugs, most of the time, 3 drugs, at least 3 drugs at one time ang iinumin mo. Isang tablet lang siya pero 3 gamot ang laman. Ethambutol, pyrazinamide, and our isa. Okay. So, yung 3 yun, iinumin mo sa harap ng nurse. Kaya siya directly observed. Okay. The problem with TB dots is 60 days ka magpapakita, at least 6 months ka magpapakita sa nurse araw-araw to get your drugs. Okay. However, it is almost guaranteed you're going to be free of tuberculosis by that time. The problem is, if hindi mo tinuloy, you will develop resistance to those drugs. And eventually, you will be given stronger drugs that can eventually destroy your liver, like in the case of streptomycin. Next, you have pneumonia. So, pneumonia is a general term for many bacterial or viral infection of the lungs that cause fever, difficulty in breathing, and chest pain. Edema in the lungs reduces their inflation ability and reduces gas exchange. Okay, so we have different types of pneumonia. We have community-acquired, and we also have our nosocomial infections. Pneumonia is lethal, especially for elderly patients. Okay, so the pattern of death for pneumonia is an elderly patient comes into the hospital with a totally different complaint. If he or she is confined, the hospital has the strongest strains of pneumonia present in the world. So they may contract hospital-acquired pneumonia, and these are very resistant bacteria. Eventually, it will attack the lungs, and upon doing enough damage, it can kill the patient. Okay. Next, you have your flu, viral infection of the respiratory system. It causes chills, fever, headache, and muscle aches. This is caused by your influenza. There is a yearly flu vaccination depending on the World Health Organization that organize anong strain ang ilalagay nila sa flu vaccine for that specific year. You also have your fungal diseases. These are fungal spores that enter the respiratory tract attached to dust particles, usually resulting in minor respiratory infections that in some cases can spread to other parts of the body. Do not be concerned with fungal diseases, even if molds and mildew is around your house. As long as you are normal human with normal immunocapacity, meaning normal lang iyong immune system, you will not develop fungal diseases. However, if you are immunocompromised or undergoing chemotherapy, fungal diseases is lethal. mahirap gamutin ang fungal diseases compared to bacteria. Finally, we have effects of aging in the respiratory system. So vital capacity and maximum minute ventilation decreases with age because of weakening of the respiratory muscles and stiffening of the thoracic cage. Residual volume and dead space increases because the diameter of respiratory passageways increases. An increase of resting tidal volume compensates for decreased dead space, loss of alveolar walls, and thickening of alveolar walls. The ability to remove mucus from the respiratory tract decreases with age. So that will be all for this lecture. Please answer your exercises. We will have a quiz by this Friday. Thank you and good day.